Bismillahirrahmanirrahim. Today my topic of presentation is techniques of economic evaluation and network analysis. You don't do evil to those who do evil to you, but you deal with them with forgiveness and kindness. Prophet Muhammad sallallahu alaihi wasallam. Learning outlines of today's presentation is introduction of economic valuation, types, components of economic valuation, advantages and disadvantages of various types of economic valuation, brief discussion about network analysis, various techniques, PERT, CPM, and some recent advances. By the end of this presentation, participants will be able to describe the introduction, types, components of economic valuation, and network analysis. Introduction. Economic valuation. It is a process of systematic identification, measurement, and valuation of the inputs and outcomes of two alternative activities and the subsequent comparative analysis of these. Existence of alternative is at the heart of economics evaluation because making decision is central to economics. It is a way to identify, measure, evaluate, and compare the cost and results of program and various policies. It is actually the comparative analysis or evaluation of two or more interventions in terms of their cost and consequences. And it is also the evaluation or assessment of different programs based on their input given and results or outcome generated. It is also a powerful tool that can help users making the most of the resources, decide between promising program options and demonstrate that benefit of your program. Actually, in economics, the concept is that resources are scarce and subsequently it is necessary to have an economic evaluation of various healthcare intervention. Because to allocate resources in an efficient way is actually need prioritization in needed. Different methods have been developed for economic valuation purposes to help guide decision and affect the policy making. Forces that enable us to use economic valuation is existence of finite sources. Prior to an evaluation, one must always check the effectiveness of the program, and there is no point in carrying out an ineffective program efficiently. Importance. Economic valuation enhances decision making, helps policy making practitioners and evaluators to be adept at conducting these analyses because demand for them is growing. Economic valuation helps to prioritize the program and make the best decision for optimal resource allocation. These are important tools for assessing economic feasibility and efficiency of health interventions. Components of economic valuation. Healthcare program take inputs in the form of labors, capital, and transfer them into outputs. Input measures is called cost, and it is mostly in monetary units or in the form of money. Diagnostic test outcome or an operation successfully completed. Outputs in the economic valuation in health economics are called effects and expressed in natural units such as percentage, detection, or completion ratio. For example, inputs cost and resource consumed in output consequences, which may be an improvement in health status. Broader measure of effect lies on utilities, which is estimation of satisfaction of the effects or patient satisfaction, and the output unit is called quality adjusted life years, the satisfaction of the time that a person has left to live. Output expressed in monetary unit as the cost, in which case the consequences are now called benefits. Cost and benefit. A cost is any negative effect on any organization result from implementation of any project. Example of the cost may be maintaining cost, environment, research and development, or labor cost. A benefit is any positive effect on organization resulting from implementation of the project. It includes increased productivity, reduction in cost, saving time. There is also a relationship between economic valuation and efficiency. Each of the technique is aimed at answering different questions. For example, technical efficiencies and allocative efficiencies. Technical efficiency is basically the choice of how to provide health care, minimize input at a given output. Means you can provide input with lesser input and with least cost, maximum benefit or output. In allocative efficiency, the choice of what healthcare to produce or provide maximum benefit subject to given resources. Technical efficiency is actually a given level of output and minimal cost, or producing the maximum amount of output for a given cost concerned with efficiency within a program. For example, when providing hernia repair surgery, it is best to provide or it is whether it is best to provide conventional surgery, laparoscopic surgery. When providing rheumatology clinic, whether it is best to provide a nurse practitioner services or consultant-based services, because in technical efficiency, we mainly concerned with minimal cost with maximum output. In allocative efficiency, program compete for allocation of scarce resources, because always there is less number or less finite resources, and therefore we allocate the resources in such a way that produce the maximum benefit by mixture of various inputs. And comparison across programs, for example, we can compare across programs such as gynae, intensive care services, and renal services. And example, should there be a need for expansion of surgery for rheumatology clinic or renal services? Now come towards type of economic valuation. Various methods are used, for example, cost minimization analysis, cost effective analysis, cost utility analysis, cost benefit analysis, program budgeting, marginal analysis, discounting, and sensitivity analysis. First of all, cost minimization analysis. It measures and compares input cost of two interventional strategies and assumes outcome to be equivalent. The benefit of two or more healthcare technology being compared are assumed to be equivalent. Hence, the analysis focus on comparative cost alone, means costs are compared alone in the cost minimization. The fundamental assumptions underlying this method are the two options being compared have exactly the same effect, and the we compare cost only, and important alternatives have not been left out. In this cost minimization, outcome of two action is equal, costs are different, and only costs are compared, and result is least cost alternative we adopt. For example, two drugs can be used to lower the level of blood pressure. No other side effects are associated with drug which we select. For example, drug A for BP control is 150 rupee per month, and other drug is 50 rupees per month, and both have the same effect. Therefore, the drug A we select and drug A we select and drug B we reject, because drug B we select and drug A we reject because the drug A has the high price as compared to 50 PKR, because this is cost effective, and therefore we compare the cost and of that strategy or healthcare facility which is least cost effective or least with least cost. In cost minimization, the quantity of effect must be exactly the same for all treatment, but also the quality of effect must be the same. Unless consequences are identical across treatment, cost minimization would not constitute a valid evaluation of treatment. Merits and demerits. It is simplest of economic valuation, very useful method in evaluating cost of specific drug. Demerits or disadvantage, it can only use to compare products or intervention with equivalent outcome or effect. In real life, two intervention may not always have equivalent outcome. Therefore, CMA or cost minimization is debatable in its nature. Since only costs are measured, it is therefore practically to say it is cost analysis technique. If outcomes are measured and found to be equivalent, then it becomes cost-effective analysis. But in this, we not measure the outcome and outcomes are same. Therefore, second comes the cost-effective analysis. Cost-effective analysis is a way to examine both the cost and health outcome of one or more intervention. It compares an intervention to another intervention by estimating how much it costs to gain a unit of health outcome, like a life year gained or death prevented. This type of analysis is used to compare healthcare technologies that have different outcomes, common one-dimensional health benefits, and which are measured in the same units. In a cost-effective analysis, outcome of two or more action is unequal. Costs are also different. Cost per unit health outcome is calculated and compare cost per unit health outcome. For example, E1 is the effect coming from intervention 2 and E2 is effect from intervention 2. The aim is to choose an intervention that supplies a unit of cost at lowest cost. Under cost effective analysis, treatment 1 would be more cost effective than treatment 2. Therefore, the cost effective ratios become if treatment 2 is more cost effective than treatment 1. In the intervention A, intervention B, or intervention C, we choose the most cost-effective intervention in cost-effective analysis. In cost-effective analysis, we can compare different intervention for the same disease, compare different intervention for reaching specific segment of population, compare different intervention for different disease. In comparative cost-effective analysis, there is no monetary value assigned to outcome. Outcome used is represented in the form of cases. For example, cost per case is detected or preventive. Death cost per death provided, years of life, disease adjusted life years. For example, renal failure cost per life saved, screening for Down syndrome cost per Down syndrome fetus detected. For example, steps of cost effective analysis. First of all, we identify two or more alternatives and outcomes and number of cases. There may be different types of intervention, alternatives of intervention. For example, the program may be independent program or there may be mutually exclusive program. In independent program, cost and effectiveness of one program is not affected by implementation of another. For example, treatment of acute respiratory tract and treatment of diarrhea among under 5-year children. In mutually exclusive, one program is implemented and another program cannot be. Program for example, two alternative antibiotics for treated AR in children. Therefore, two programs may be independent and mutually exclusive. Therefore, then we identify the perspectives of costing. In cost analysis, different perspective may be, for example, patient and family opportunity cost, healthcare provider cost, Ministry of Health salary paid to officials, storage, transportation cost, societal, for example, foreign assistance, family member taking care of sick. Then determination of cost. Cost for each course of action should include both direct and indirect cost, and therefore we measure the cost. Then costing non-market items, for example, volunteer time, family of patient waiting time. There may be two approaches: opportunity cost, which is the valuing the time of person at the wage or income the person would have earned, or market cost. What would be the cost if hospital or clinic hired someone to do the work volunteer has performed? Then we determine the cost effectiveness ratio. Different approaches based on alternative. For independent, average cost effectiveness ratio is the on the cost numerator, and in denominator there is effectiveness or health outcome output. For mutually exclusive program, we measure the incremental cost effectiveness ratio, which may be cost of new program minus cost of current program divided by effectiveness of new program and effectiveness of current program. Cost effectiveness ratio for mutually exclusive order program according to their effectiveness. Calculate the incremental cost effectiveness ratio. Eliminate dominated alternatives. Decision making for independent program, ACER or adjusted or average cost effective ratio. Implement program in the order of their ratio until the budget is exhausted. Lowest ACR is most effective and hence given the highest priority. Decision making for mutually exclusive programs, we are comparing program B to program A. Easy case, B is more expensive and less effective. We prefer A dominant B. If B is more less expensive and more effective, B dominates A. There is also cost-effective claim. In this, if the intervention is less effective and more costly, we exclude it. If intervention is more effective and more costly, it may be questionable. If intervention is less effective and less costly, it may be questionable, we may include. If intervention is more effective and less costly, it may be dominant, because in the cost-effective analysis, our main aim is to adopt this intervention which is cost-effective. Choosing the best strategy, choose the most effective strategy. Guide and use gross domestic product to drive categories of cost effectiveness. Errors to avoid during cost effective analysis: reporting ratios of total cost to total IVRs. We can sometimes failing to exclude strongly or weakly dominated strategies, claiming that strategies with the lowest ICR incremental cost effective ratio is the best choice. CA can be undertaken at two distinct stages of program implementation: at prospective analysis that take place prior to start of pilot at scale program, or retrospective analysis take place after an evaluation of program is completed. Therefore, prospective analysis or retrospective analysis at two levels. Challenges to do cost effective analysis. There may be absence of incentive to do cost effective analysis. Assumptions are required. Number of assumptions are needed to complete the analysis. For example, multiple outcomes, spillover effects, exchange rate, discounting, inflation. Costs are harder to gather. Collection of costs that are not easy a key part of valuation. Cost data is surprisingly hard to collect from implementers. Reliability of cost effectiveness. Though the basic cost effectiveness calculation appear to be simple, but choices for unit of measurement, definition of intervention, scope of cost, and prices to be included. In many cases, the differences are so large that defining the underlying analysis is unnecessary. Limitation of cost-effective analysis. They does not inform whether or not to expand to scale up the program, don't take on the social desirability of health outcome, provides information about technical efficiency rather than allocative efficiency, cannot compare intervention with different consequences, cannot compare program with different goals, compare disparate alternatives. It is narrow unidirectional measure of effect. Intervention often produce multiple outcomes. Cost now comes the cost benefit analysis. It is actually the quantitative analytical tool to aid decision maker in efficient allocation of resources. It provides a systematic assessment of cost and benefit associated with intervention. It is a form of economic valuation through which questions primarily of allocative efficiencies are addressed, because in cost effective we deal with technical efficiency. In economic theory, there is also a benefit as change that increase human well-being, a cost as change that decrease human well-being. For the purpose of comparison, these increase and decrease in well-being are measured using money as common denominator. All cost and benefit included in CBA are quantified in monetary terms in the form of money. Cost are money, for example, in dollars, PKR. Outcome is also in money. Result is net benefit or cost benefit ratio. Steps in CPA. For example, we define the objective of intervention, define the baseline, what would be happen, action is taken, define the alternative option to achieve the objective, quantify the investment cost, identify and quantify the positive and negative welfare effect of each intervention, value the welfare effects in monetary terms using market prices and economic valuation. Step is to calculate the present value of cost and benefit occurring at different points in time using discount rate. Step 8 is calculate the net present value or benefit cost ratio, which is benefit divided by cost, or net benefit present value or ratio of alternative option. Perform a sensitivity analysis, and step 10 is to select the most efficient intervention option. Two approaches: risk ratio, which may be cost benefit ratio, cost divided by benefit, or benefit cost ratio, or net benefit approach. For example, we calculate the net benefit, which is total benefit minus total cost. Cost benefit analysis is net benefit of change, which is benefit minus. The change is said to be economically efficient in cost benefit if net uh, productive or net positive value, if net NPV is positive and ratio of total benefit to total cost, or B or C ratio is more than 1. CBA is multidisciplinary process and involving economists, expertise from different fields, the input from policy and decision makers. BCR is, or benefit cost ratio, is actually an indicator showing the relationship between relative cost and benefit. If project have BCR greater than 1, the project is expected to deliver positive net present value to firm. If it is less than 1, the project cost outweighs the benefit and it should not be considered. Why CBA? It provides a consistent framework for deciding intervention desirable, estimate the benefit in monetary terms, estimate benefit in monetary terms, and allow comparison of different types of merits in the same units. To determine the net impact of project, it may be positive or negative. In healthcare context, CBA should be used rather than other types of economic valuation, because it is only method that can tell whether an intervention is worthwhile. Uses mostly common use for public decision, for example, policy proposal for grants, projects, accepting or rejecting a single project, choosing the appropriate scale or timing for project, choose one of number of mutually exclusive project, choosing a number of discrete alternative projects, evaluating government policies, notably not only relating to government regulations. It helps to establish a culture of accountability, evaluate projects or policies post rather than pre. CBA provides valuable feedback to staff which can help improve performance within the intervention. Strengths: its systematic way of thinking and analysis focus on use of space resources because it deals with allocative efficiency. Strong methodological basis, monetary measurement provides comparison, appeals to policymakers. Limitation: it is one approach to assess the efficiency of policy or program, uncertainty of all parameters used, estimated values of objects at risk, probability of hazards. For example, childhood immunization. There is hypothetical CBA analysis for child immunization. Monetary benefit is total 1.2 billion. and monetary cost running is 66 billion 6 lakh dollars per year, and ratio of benefit to cost equal to, which can be expressed as 2:1. In cost effective analysis, if we spend $1 and buy Hemophilus influenza vaccine, the cost is in dollar and outcome is in the form of health outcome, mean we avert infection decrease by 1 case. Cost benefit analysis, cost in the dollar. For example, if we once spend $1 of Hemophilus influenza vaccination, we earn $5 because we avert work leave by averting infection, which is also in the form of money in cost benefit analysis. Now come cost utility analysis. It is a subset of cost effective analysis. In the course's monetary term, outcome presented in terms of quality tested life index or Delhi or Quali measure the effect of intervention on health unit that measures both quantity and quality of life. It can address both technical and allocative efficiency within the healthcare sector. Cost utility analysis, generic measure of disease burden, including both quality. It is used in economic valuation to assess the value for money of medical intervention. Um, one quality is 1 year of life lived in perfect life and zero is death. Cost utility analysis is common evaluation exercise and it is a special case of cost effective analysis. In the steps, identification of two or more alternatives, identification of perspective, determination of cost, determination of outcomes in utility terms, and calculation of cost utility ratio and decision making. Therefore, further outcome in quality adjusted life year or disability adjusted life years. Calculating the quality adjusted life years or cost utility ratios calculated at the end is cost of intervention A minus cost of intervention B and number of quality tested produced by intervention A minus number of quality tested life years produced by intervention B. For example, cost and effect for alternative gallstone treatment in open cholecystectomy, quality loss is 0.16, in laparoscopic 0.12. Cost utility analysis have important implications for allocation of sources. It generally restricted to efficiency with which health services resources are used. It advantages facilitate comparison without recourse to placing unitary values in different health states with all the technical and ethical challenges associated. It can capture the value of improvement in morbidity and mortality. It facilitates the transparency of resource allocation processes. Disadvantage: absence of agreement in measuring utilities. Results are often difficult to reproduce among different evaluators because of variation in methodologies. Problem with quantification of patient problem. Absence of agreement in measuring utilities. Now come with program budgeting and marginal analysis. Another economic framework that can aid in priority setting and allocating resources program budgeting, which is retrospective appraisal of resource allocation broken down in mini program with a view to tracking future or resource allocation in those of program. Marginal analysis is assessment of added benefits and added costs with new investment is proposed in an incremental way. Marginal analysis change in the amount of mix of services provided for given population identified. The aim of marginal analysis is to maximize benefit and minimize opportunity cost while considering other important principles such as equity. Steps may identify program, statement of expenditure and activity by subgroup, decide on services which are candidate for expansion, measure cost and benefit of program, make recommendations. Program budgeting and marginal analysis is actually a framework that highlights the use of local cost and activity data, accessibility and availability of effectiveness evidence. It starts by analyzing the activity and expenditure data of existing services and then goes on to examine marginal change in these services, rather than starting with blank piece of paper. For example, managing resources in NHS and using health economics to inform commissioning decisions. Another is sensitivity analysis. In economic valuation, some form of sensitivity analysis is frequently carried out in order to allow for uncertainty. Because uncertainty may exist, there may be data are unavailable, assumptions are unnecessary, and available data may be inaccurate. Sensitivity analysis is the result of valuation or rework after systematic substituting high and low values for each variable of interest. If the conclusion remains unchanged after the reanalysis, then the results can be said to be robust. If the results are no robust, then sensitive analysis can show where better information will be used. Sensitivity may be simple or probabilistic sensitivity analysis. In simple, we entail varying one or more component of valuation to see how it affects. In probabilistic sensitivity analysis, assign range and distribution to variables and computer programs. There may be also the method of discounting, which refers to process of adjusting the value of cost and benefit that occur at different points of time in future. Discounting is necessary if there is preference to defer cost until tomorrow to enjoy the benefit below. Discount rate describes the interest rate with which the present value of future cost and benefit is estimated. Economic evaluation conduct how we can conduct the economic evaluation. Two approaches we can conduct alongside RCT, randomized controlled or non-randomized control. We can collect primary data, rely on existing or secondary data of existing studies. Application economic evaluation, it is tool to aid priorities, setting resource allocation. It provides recommendation on the use of new and existing medicine and treatment. Recommendation are based on impact. In cost minimization, we compare only cost. In cost effectiveness, values in dollar and outcome is in the form of health unit. In cost utility, outcome in form of Delhi or Valley. In cost benefit, outcome is in the monetary terms or dollars. Now comes the network analysis. It is a graphical plan of all health activities and events to be completed in order to reach an objective. Two types of network analysis: PERT, project evaluation and review technique, or CPM, critical path method. Its objective is to successful technique currently used to plan, monitor, and control the project involving thousands of activities. Its objective is to minimize project costs, minimize project time, to ensure optimal utilization of human resources, to ensure minimum conflicts and unnecessary delays. Basic concept in this, there is an activity which refers to physically identifiable part of project which consume time and cost, and activity is entered by arrow. And there may be activity should be entered by arrow, or there may be forward direction, downward direction, but it can never be in reverse direction. For example, activity shown by arrow. An event represents the start and end point of an activity. An event is represent the start and end point of act. There may be an event represented by the start and end point. It is normally denoted by nodes in the network analysis. Therefore, network analysis consists of different events and activities, and event is noted by nodes. In the what is PERT, project evaluation review technique, it's a method of analyzing the task involving completing the project. It is especially the time needed to complete each task and identify the minimum time. In most of health projects where activity times are not known, PERT can be used for planning. It is more event-oriented technique rather than start or completion-oriented, where time is the major factor rather than cost. PERT offers a management tool which allow an arrow and node diagram of activities and events. For example, a project which can take 4 months, and therefore different error in the form of PERT analysis. For example, we plan a service and 4 months staff recruited, 2 months staff recruited, and equipment order, and therefore total equipment installed, start providing services, and terminal went. Critical path method, CPM, is critical path analysis, another method for network analysis. It is commonly used in conjunction with PERT. A critical path is determined by identifying the longest stretch of dependent activities and measuring the time required to complete them from start to finish. It calculates the longest path of planned activities to logical points or no end of project. This process determines which activities are critical or which have total float, or which cannot be delayed without making the project. Used in construction, aerospace, defense, software development, search and development. Critical path is overall the longest path. In the figure, shows that this is highlighted line. This is the longest path a project can take, and it is 40 weeks. And if there is any delay, which can lead to delay in project. PERT is probabilistic and CPM is deterministic. It is used for PERT is used where in project where time requirement to complete activities not known, but in CPM or critical path used for projects which are repetitive in nature and where we have previous experience and we determine the time. PERT is used in research and development mostly, and it is used in maintenance and construction work. Does not consider cost PERT, but it deals with cost of project scheduling and their minimization. It is based on event, PERT, and CPM is based on activity. Activity time is not subjective and activity time is subjective. Recent advances. There is a systematic review which identify the use of health economic evaluation in implementation and improvement science field, which indicate that application of economic evaluation method is needed and evidence was critically placed using quality of life economic studies. 30 studies were included and mostly studies were from um, uh, Europe and America, and the field was mostly split between improvement and implementation. Most studies were ex post economic evaluation carried out empirically, and 17 were cost effective analysis. And they found that 4 post utility analysis that use economic modeling rather than empirical methods. The quantity of published economic evaluation applied to the field of improvement and implementation research remain modest. However, the quality is overall good. Implementation and improvement scientists should work closely with health economists to consider costs associated with improvement in intervention. Another importance of economic valuation in Indian perspective is that though the economic valuation is minimization effect is known, but there has been uncertainty in the conduct of sub-economic valuation in India or basically in developing countries, and most economic valuation is conducted in developed countries. And the perspective is that though there may be are different in decision making adopted, and most commonly the question of public subsidies with purchase medicine, there are limited events and evidence on impact of health insurance on the health and economic well-being of beneficiaries in developed countries. Nature, scope, and use of economic valuation in healthcare program is special reference to Pakistan. In economic valuation is actually the emerging field in areas and very limited in Pakistan. We find in this study, they find that cost-effective analysis are core competency and skill of medical doctor in undergraduate medical curricula, yet we could not find any economic evaluation in recommended textbook. They found that both cost and practice should be included in analysis because there is little awareness about these methods, and this must be comparison with lead to drugs or medical intervention. And they describe that they must be added in medical and public health curricula in Pakistan. There is also thesis about economic evaluation of community level intervention of preeclampsia in Sindh. This dissertation is to conduct preeclampsia about two drugs which combine the community level intervention of preeclampsia CLIP with routine pregnancy care. And this thesis used mixed method approach, qualitative and quantitative approach, a literature review of published and economic valuation used as reference. Result of this shows that the most economic valuation studies from developed countries and focused on cost to health system. Focus group reveals a large burden of out-of-pocket spending, and it shows a negative health gains -37. And this dissertation highlights a knowledge gap for cost and cost-effective analysis, intervention in low and middle income countries, and most economic valuation that CLP community level intervention is not cost-effective strategies compared to routine pregnancy care. And more research is needed to conduct process evaluation to inform policy decision on resource allocation in Sindh, Pakistan. MCQs. Cost-effective analysis of child immunization program in XYZ community estimate that monetary cost is 6 billion, monetary benefits 1 billion in the form of direct cost and dose work time cost. What will be net benefit of change in this? It may be net benefit of change benefit minus cost 140 or minus 6, and the answer will be 134 billion, which is E. MCQs 2, a cost benefit analysis of two health projects. What will be cost benefit cost ratio of both projects? The total cost of project is 80,000 and it is 11,000 total benefits, and this is what is the benefit cost ratio? It will be 0.15 in A and 1.81 in B. Therefore, correct answer is delta. MCQ 3. Of health economics conducted cost benefit analysis of ongoing two health projects and calculate benefit cost ratio BCR of two projects. Which project is economically more efficient and why? Project A 3.3 and project B 0.13. What will be correct answer? C is correct answer. Project A, because in this BCR value or benefit cost ratio is more than 1, which is 3. Therefore, it may be economically more efficient because it has value more than 1. A cost-effective analysis of 4 health program in X, Y, Z. Which program is more cost effective? Program A cost 10,000 and 50 lives saved, cost B 30,000 and C. What program is more cost effective? C is correct answer.
A.
A, because it saves 50 lives and cost is less. MCQ 5, in quantifying the value of ongoing nutritional education program in middle school children, public health economist goal is to express benefits associated with this in dollar value. Which economic valuation method he should employ? Benefit, effective, utility analysis, minimization analysis. It should be benefit analysis because program estimate the value in dollar, which is in monetary, and in cost benefit analysis is monetary value. CEA economic valuation method would be best applied in which of following cases? Case 1, spend 1000 by and outcome is worth decreased by 1 unit, and case 2, spend by nucleus influenza vaccination and avoid leave by working, and in case 3 or case 4 cost effective analysis. In case 1, because it spent money in the form of money and health outcome is the avoid infection. Therefore, C is correct answer. Program results from cost effective analysis screening intervention program preventing HIV/AIDS infection among 1,000 high risk women in ABC community. Cost, total cost, net cost is 1 lakh or change in outcome is 10 pelvic inflammatory disease cases averted. What will be answer? C is the correct answer because 10,000 divided by output 10,000 PPR by PLT case averted.